Again, this is Richard Mollett with the Long-Term Care Community Coalition. Welcome everyone to our program today. I see people are still joining us, but I'm going to start off with some background material and hopefully everyone will be on by the time our guest speaker is ready to speak. For materials from today's webinar, please visit our homepage, nursinghomes411.org/webinar-admissions-discrimination/. And if you're as you can see, this is at the bottom of your screen in the orange box. A few meeting tips for today's meeting. As with all of our webinars, we ask that you put questions in the Q&A in the Zoom. Please do not put questions in the chat, and please also do not raise your hand. We don't have the capacity to accommodate that. We will be monitoring the Q&A for questions, which we are leaving time at the end to discuss. If you have any technical issues with the meeting, please note that in the chat and we will do our best to assist you. A couple of quick things quickly at nursinghomes411.org. We have a couple of new policy briefs out. One is a policy brief on culture change. We did a webinar on that last month. We also have two policy briefs related to minimum spending ratios, meaning the trying to encourage policies and support policies that require nursing homes to spend a minimum amount of money that they receive for care actually on care. We have one in support of New York State's direct care minimum spending ratio, which went into effect just a couple of weeks ago. And we have another that is for both state and national advocates that is more general, but it cites New York, New Jersey, and I believe Massachusetts, three states that have passed minimum staffing ratios in the last year. Without further ado, I am going to move on. Quickly, an introduction to the organization for those of you who haven't attended our programs before. The Long-Term Care Community Coalition, LTCCC, we are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for residents in nursing homes, assisted living, and other long-term care residential settings. Most of our focus is on policy research and analysis, and from that we do systems advocacy. We also, over the past dozen years or so, have been doing more and more public education, including programs such as this. We do a monthly program, usually on, I think, the third Tuesday of every month at 1 p.m. Eastern. We put out a lot of data, as hopefully you all have seen, as well as information, resources, tools, and forms that families and residents and those working with them can use to find out about what's going on in the nursing homes in their community and to advocate for better care. Lastly, about LTCCC is that we are the proud home of two local long-term care ombudsman programs here in the Hudson Valley of New York State. All of the materials that we have are available for free to use, to share, to adopt by other organizations at www.nursinghomes411.org. So today's webinar is entitled Picking Patients for Profits, Admissions Discrimination in Nursing Homes. I'm really excited to have today as our guest speaker, Professor Ashvin Gandhi. He's an health economist, at the UCLA Anderson School of Management. He has done a lot of really interesting work in regard to many different issues, financial and economic issues, but in particular of interest to our audience today, a number of different studies over the years on nursing homes, including most recently a study on the subject of today's program, but he's done other studies as well. Unfortunately, I'll try to find this when he's speaking, but I closed out of my web browser, but I was just admiring his body of research. He's, of course, at UCLA, so if you go to UCLA's website or look him up in UCLA, you can surely find it, but we'll try to post that in the chat as well so you can see some of the work that he has. And without, actually, I just wanted, before he started to speak, that's it. I thought I had another slide, but I am going to stop sharing so he can share. Welcome, Professor Gandhi.
Thanks so much, Richard. Let me see if I can share my presentation. Let me know if that all looks okay for you.
Looks good.
Great. Thanks so much for that introduction. I'm very excited to be here with all of you today to tell you about the work that I've been doing on admissions discrimination at nursing homes. Just a little bit about me. I'm an assistant professor at the UCLA Anderson School of Management. I'm a health economist by training. I do a lot of research, especially in long-term care and especially on nursing homes. Some work I've done regards, what I'm going to talk about today, admissions discrimination at nursing homes. I also do a lot of work on the nursing home workforce and understanding things like how severe of a problem turnover is in the industry. I'm going to devote a little bit of time at the end of my presentation today to sort of previewing a little bit of what we're seeing there in terms of really high turnover rates in the industry. I also look a little bit at the finance end of the nursing home industry, trying to understand the impacts of acquisitions, for example, by private equity firms, or what happens when nursing homes go bankrupt and how does that affect staff and especially residents. And then lastly, in the last couple of years, I've spent a lot of time looking at COVID-19 at nursing homes and trying to understand what factors are really important for protecting residents from outbreaks, things like staff vaccination rates being really critical for protecting residents, testing and other quality factors that can help mitigate and prevent outbreaks. So I have my contact information at the bottom of this slide. If any of you ever have any questions or want to reach out about long-term care issues, please don't hesitate to email me or tweet at me. I'll also put those up at the end of the presentation. Okay, so I'll start by previewing the results I'm going to show you. And what basically I'm going to tell you is that admissions discrimination at nursing homes is really, really widespread. So almost 20% of residents, and these residents are about 40% of days of nursing home care, aren't at their first choice nursing home. What that means is that those residents would have preferred to go to another, probably higher quality facility or one that's maybe closer to their home, but they're not able to get in. And these instances I'm going to show you are not cases where the facility literally doesn't have beds available. They have beds available. Those facilities are simply not making those beds available to these residents. They're particularly discriminating against these residents in their admissions practices. Now, the evidence I'm going to show you is going to be consistent with facilities discriminating against patients who are on Medicaid, who have really, really long anticipated stays, who suffer from disabilities that require more intensive care, and even some evidence that there may be a racial component here as well. The policy solutions here aren't actually going to be obvious. I'm going to show you a little bit about what my research suggests would happen if we followed a few of the policies that people have suggested to try and address these issues. And there's often trade-offs that we face, and they're not always as effective as we think they might be. So it's a pretty tough issue to address. Now, access to high-quality facilities really matters, and COVID-19 has made this really, really salient because there's a huge amount of variation in whether or not residents end up getting COVID across facilities, depending on factors such as the facility's size, location, staffing. Do they have a large staff, a small staff, a well-vaccinated staff, a staff that's frequently tested? And so having access to a smaller facility, a better resource fund that has more testing, or staff that are more vaccinated, can actually reduce residents' risk dramatically of contracting COVID and then having the really severe adverse health outcomes that has for older Americans. Now, access to high quality facilities was important long before COVID, as I'm sure all of you know. I think the best research on this is from Ben Friedrich and one of my colleagues at UCLA, Martin Hackman, where they look at staffing levels at nursing homes, and they find that if you have 1% less staff, it correlates with a 1.9% increase in the mortality rates of residents. And so being able to go to a facility that has better staffing, higher quality, even if we set COVID aside, which is the most extreme case of this, has really, really dramatic implications for the health and welfare of these older Americans. So before I actually get into my research, I want to talk a little bit about whether or not this is legal. And an important disclaimer here before I jump in is that I am not a lawyer. I'm going to try and give you my best understanding of the law, as well as existing case law and the way that facilities and practitioners appear to be interpreting this. But of course, a lot of this is going to be subject to interpretation, and some people may disagree. And unfortunately, what I'll tell you is that some of this is not really well defined in the legal system yet. So I'll start by talking about disability discrimination, because actually this one's really clear. Disability discrimination, discriminating at admissions based on disabilities that residents have is very clearly illegal under the Rehabilitation Act, the Americans with Disabilities Act, and even the Fair Housing Act, because nursing homes can be considered basically housing. And so there is existing case law. Take, for example, there's this Wagner versus Fair Acres case, where Fair Acres wanted to turn away a resident because that resident had dementia. And Wagner and Fair Acres could provide Wagner with the care that Wagner required. They simply didn't want to because it would have been more costly for them to provide that care. And so Fair Acres tried to turn away Wagner, and the court decided in this case that that was illegal disability discrimination against Wagner. Now, there is a key exception to this rule, which is that facilities are legally allowed to turn residents away if they're not able to provide the level of care that those residents require. Now, what I'm going to show you is that that's actually not a very common thing. Often the types of residents that are being discriminated against are being discriminated against for their payer status, for example, rather than the care needs. And the care needs they need might be staff time intensive, but they probably don't require physical equipment, for example, that isn't there. It's simply a profitability thing. And so there probably isn't that much leg to stand on in the real world that looks like this Grubbs versus Medical Facilities America case. Medicaid discrimination, on the other hand, is a little bit less clear. So if you take a look at the law, there's a very clear intention to ban admissions discrimination against Medicaid patients, meaning turning away patients simply because they're either on Medicaid or you anticipate that they're going to be on Medicaid. And facilities, by the way, are very sophisticated about this. You can go online and you can buy software where you can put in information about a resident and it will predict based on their current assets when they're going to end up on Medicaid. And facilities will often use that to decide whether or not to turn away patients. Now, the letter of the law says at the federal level, you can't request or require residents or potential residents to waive their rights, including but not limited to their rights to Medicare or Medicaid. You cannot request or require oral or written assurance that residents or potential residents are not eligible for or will not apply for Medicare or Medicaid benefits. And so this, especially in conjunction with the Senate hearings that were held prior to the passage of this act, make it very clear that Congress was intending to prevent admissions discrimination against Medicaid patients, which was at the time really, really rampant and really, really explicit. But there's a potential loophole here that a lot of facilities seem to be trying to exploit, which is they won't say you need to forego Medicaid in order to be admitted to this facility, they'll simply look at the resident, ask for their financial status, and then deny admission based on the fact that they're on Medicaid or are going to be on Medicaid. And so it's a clear violation of the intention of the law, but some facilities would argue that it possibly satisfies the letter of the law, in that if we go back here, they're not requesting or requiring oral or written assurance, they're just denying you outright. And so I would argue, from my perspective, that that seems to be a violation, but I've talked to some very good and well-known lawyers, some of whom agree with me, some of whom believe that facilities might be able to get away with this if this came to the courts. In the end, we don't really know yet because there's no good case law on this issue as of yet. And that's for a number of reasons. There's, I think, a lack of awareness of exactly how prevalent admissions discrimination is. The admissions discrimination here is going to affect often the most vulnerable populations, people who are on Medicaid, people with disabilities like dementia. And so they may not have available advocates all the time. And where they do, and some of the advocacy lawyers that I've spoken to about this have said that usually when a lawyer gets involved and challenges it, the facility will back down and admit the patient, but then it doesn't end up going to court. And so we don't have any actual case law here that really solidifies exactly what the interpretation of that language is. So I think this is actually a point in my talk for pointing out that this is a place where there's a clear role for advocates. My research is going to show you that these problems are really, really prevalent, but that's not enough. We actually need lawmakers and regulators to do more to help codify and build on those rights. So regulators here need to take a very clear stance about the practices, what practices are legal and illegal, because there's very little case law, especially in the case of Medicaid discrimination. And I've reached out to the Office of Civil Rights at Health and Human Services. I've spoken to people at MACPAC, at Ombudsman, et cetera, and none of them will advise specifically on the record what they believe to be legal and illegal. And without sufficient advocacy to push them to take a stand, it'll ultimately stay a gray area, I suspect. In talking to ombudsmen, because this issue sort of flies under the radar, what they've told me is, it's not really on their radar. One even said, I wouldn't even know what box to check. This doesn't get reported to me often enough, often because if you're a resident looking for a nursing home, you don't have the time to litigate whether this nursing home is refusing you admission. You need to get in somewhere. And so it's very hard to get that resolved sufficiently quickly with ombudsmen. And so often those who are discriminated against aren't able to get appropriate relief. Lastly, when Health and Human Services has tried to do their own internal surveying, they asked Medicaid officials how often this happens, discrimination against Medicaid patients, and only 4% of them thought that financial screening against Medicaid patients happened with any frequency. They also surveyed hospital discharge planners who help residents find spots at nursing homes, and 70% of them said that it happens very often, or often or very often. And so there's this big disconnect, I think, between maybe regulators not realizing how prevalent this practice is, but anybody who actually works in the industry knows that it's very prevalent. So now I'll tell you a little bit about the research that I've done here using actual data on all California nursing homes between 2004 and 2007. And the data I use in my analysis is basically health assessments and claims and enrollment data for basically every resident at every nursing home in California during that period. Now, the key challenge in doing this type of research is going to be, we don't see directly where residents wish they could have gone, where they applied and were turned away. And sometimes they may wish to go somewhere, but they didn't even bother to apply because, for example, their discharge planner at the hospital said, don't even bother, they're not going to let you in. In fact, one facility manager in California told me that in their county, everyone signs up for a service where every morning discharge planners basically post profiles effectively for residents they're trying to discharge that day to or patients they're discharging that day to nursing homes. And facilities will basically go on to this service and, like Tinder, swipe right or swipe left to express interest in whether or not they're willing to admit certain residents based on their payer status and health characteristics. And so then the discharge planner will use those expressions of interest to guide what they show the patient as they're trying to pick out a facility to go to. So the question becomes, if we don't see people actually being turned away, how do we know whether or not there's discrimination happening? Right? One way to do this would be to simply observe that patients who are on Medicaid or patients who have disabilities end up at lower quality facilities. And there's a long running research that has shown that that's the case. Unfortunately, there's, at least in the academic field of health economics, there are people who are often skeptical of using that sort of evidence because they argue, well, Medicaid residents and residents who have Alzheimer's, dementia, they may live in areas that are poorer and therefore have lower quality facilities nearby them, or they may have very different preferences than residents who are healthier or more affluent. And it may be that residents who are healthier or more affluent have more help from family to help them pick out better facilities. And so how do we know there's actual discrimination going on versus something else like richer people have better help picking out facilities? And so I'm going to show evidence of discrimination that's very robust to these kinds of skeptics' criticisms that are very hard to deny. So the idea behind what I'm going to do is I'm going to look for patterns of discrimination that are not just consistent with discrimination, but are consistent with really sophisticated discrimination. Basically, if you think about a really smart facility, they should discriminate more when they have very few beds open. Because when you have many beds open, if you admit a low profit resident, you still have many beds left to be able to admit higher profit residents. But if you have very few beds left, you might, for example, give away your last bed to a Medicaid eligible resident who's a long stay resident who's going to take up that bed for multiple years, and then have another much more profitable, say, short stay Medicare, low care needs aside from their highly profitable rehab care resident come along, and you won't have a bed available to admit them. And then you're foregoing a lot of profit at that point. And so a smart facility will adjust how discriminatory it is based on how many beds they currently have available. And the way I'm going to identify discrimination is based on that pattern of not just discrimination, but super sophisticated discrimination. So does the same facility change who they suddenly seem willing to admit based on the availability of open beds at the time? And the short answer is yes. Yes, they do. So here I've just plotted the average length of stay, Medicaid utilization, visual acuity or visual impairment index for residents who are admitted in the bottom 5 percentile of facilities occupancy versus the top 5 percentile. So the orange bars here represent the typical characteristic of a resident who's admitted when the facility is on one of their least full days. The blue bars represent the characteristics of typical residents who are admitted on a facility's most full day. And what you see is that as facilities become more full and it becomes more costly to admit less profitable patients, suddenly you see them admitting fewer long-stay residents who, of course, tend to be on Medicaid and not get the high reimbursement rates of Medicare residents on average. You see them avoiding Medicaid patients. You see them avoiding residents who have visual impairment. And so this evidence is really consistent with facilities adjusting how discriminatory they are based on how full they are. Now, I want to be clear here. What we see is, say, for example, with Medicaid utilization, we see a 10% or so difference in the rate of residents that you admit who are on Medicaid when you're very empty versus very full, or on your least full and most full days. But that doesn't mean that there's only 10% discrimination. What that means is that there's 10% variation in discrimination for the same facility over time. So some facilities are going to discriminate all the time. Some facilities are going to discriminate never. And on average, what this is showing is that some of them are changing how much they discriminate over time, depending on how full or empty they are. And on average, that degree of variation is 10%. So you should think about the level of discrimination this represents as being much higher than 10%. It's just that the variation is 10% within the same facility. So we can actually do something a little bit more technical to deal with the following challenge, which is that residents, of course, have many characteristics. It's not just whether they're on Medicare or Medicaid. It's not just whether they have visual acuity problems or whether they have ADRD, or you could even have a racial component, age components, et cetera. There are lots of characteristics that we might be concerned that facilities are discriminating in their admission practices on. So the idea that I'm going to use here is I'm going to borrow machine learning methods to ask a computer to basically learn from the data who is discriminated against based on what types of patients are typically admitted when less full. So if we see that a certain type of patient tends to be admitted a lot more when facilities have a bunch of open beds, but then turned away a ton when they have very few beds left, that's a sign that that's a characteristic that's really strongly correlated with admissions discrimination. And so we can put in hundreds of characteristics into the machine, ask it to learn, which ones seem to have a lot of predictive power in whether or not facilities are discriminating. And so here, just for visual simplicity, I've asked the machine to take those scores and basically assign point values to how approximately important or relatively important these characteristics appear to be. So there's a lot of predictive power here in whether or not a resident is discriminated against, depending on whether they're on Medicaid. And depending on whether or not it looks like when they're admitted, they have characteristics that indicate they're likely to stay at the facility for a really long time. We also have some points here are a bad thing, just to be clear. That's where the machine pops out for how discriminated against a characteristic appears to be. We see that residents who seem likely to have conflicts with other residents or conflicts with staff or inappropriate behavior also seem to suffer some degree of discrimination, though not to the extent of Medicaid and very long stay, which are sort of the dominating features here. We see that residents who have visual impairment or are higher needs DRGs or who require antipsychotics also seem to suffer from this. And even after controlling for all of the above, there still seems to be a little bit of a racial component here that's not well explained by the other characteristics. And so there may even be some underlying racial discrimination, though we have to be a little bit cautious in interpreting some of this because it may be correlated with other characteristics here. So one thing we might want to do is take some of this evidence and try and think about what policies might be effective for addressing these issues. And so what I'm going to do is statistically fit an economic model, we call this a demand model, of which facilities residents want to go to, i.e. residents' preferences over facilities, like do they like facilities that have better staffing, that are located closer to their home, et cetera, while simultaneously fitting a model of facilities preferences over residents. So we see that facilities seem to prefer residents that are on Medicare rather than Medicaid, who tend to be very short stay, who have fewer complicating health characteristics that require additional care. And this type of modeling is very common in economics research. It's especially common in competition and antitrust research, where they try and estimate the impact of, say, for example, a monopoly in harming consumers. So here we're going to use that same type of set of tools to understand what the harms here are to the residents that are being discriminated against. And it's also really commonly used in industry. Basically, every tech company you can think of, Amazon, Uber, Google, et cetera, have whole teams of people who implement these methods. The value here is going to be that we're going to get a really precise measurement of the problem. That's where I get those numbers for you of, 19% of residents aren't able to go to the facility they want to go to. And that those residents constitute 40% of care days. And I'm going to be able to actually simulate out what happens if we tried to solve this problem by raising the Medicaid reimbursement rate, or by simply enforcing the prohibition on discriminatory admissions practices. So when we measure the problem, again, we find that almost 20% of residents are not at their first choice facility. And that number is way higher for these very long stay Medicaid patients. Basically, half of them are not able to go to the facility that they probably wish that they could have gone to. And these Medicaid residents would have gained a lot from being able to access better care. Now, one thing I do find is that there is some truth to the argument that maybe Medicaid beneficiaries care a little bit less about some of the traditional quality measures for like RN staffing, but they care a lot more than I think the previous economic literature, at least, which argued that the fact that we see Medicaid patients go to low quality facilities is because they don't care about quality. It turns out they may care a little bit less about quality, but really a big part of it is those good facilities are turning them away or are avoiding them even knowing that they exist. So some of the policies I look at to try and address the issue, one is, what if we just implemented first come, first serve? We said facilities are not allowed in any way to pick their residents, and we're going to enforce that. So what we see is that there's actually pretty large benefits to Medicaid residents. Basically, they would value this better access to quality care at about $10.09, basically $10 worth of additional registered nurse care per day. And so it's actually a pretty substantial benefit. They're really being harmed by not having access, these Medicaid residents, to high quality facilities. Doing this, though, would harm short stay Medicare patients, right? So actually most residents are short stay Medicare residents who are only there for a few days or a few weeks and then leave and go home. And because Medicare reimburses so much better than Medicaid, it tends to be that Medicare residents have really good access to quality care, and providing better access to Medicaid residents through a first come, first served system would have an adverse consequence for some Medicare patients who then are not able to get into their preferred facility because the last bed is taken up by a Medicaid resident. So there is some trade-off there, but the harms are not very large because by and large, these Medicare residents are reimbursed so well that they can go to their second or third choice facility, and it tends to be a very good facility anyways. So overall, there's it benefits residents overall, but there are some that benefit and some that are hurt. We could also look at raising the Medicaid reimbursement rate, and I think this is probably what the industry would advocate for. We're discriminating against Medicaid patients, so you should raise the Medicaid reimbursement rate to make Medicaid residents more attractive. And so I simulate out what would happen if we did that. You know, in California, at the time period I studied, matching private pay rates would involve basically increasing Medicaid reimbursement rates almost $40 a day. But actually, it doesn't provide much better access to care. It's only really benefits about 72 cents per day worth of care. So we pay a lot and actually get very little. And that seems a little counterintuitive, but really what's driving that is that raising the Medicaid reimbursement rate doesn't increase access by that much, because the available capacity at the really high quality facilities is still really, really limited. You might get access for a few additional Medicaid residents, but you're paying $40 a day more for all of them. And so the cost benefit analysis makes that very hard to justify. Buying access that way alone isn't worth it. What you would have to believe for raising the Medicaid reimbursement rate to work as a policy to improve quality dramatically for Medicaid residents is that you'd have to believe it takes facilities that are low quality and motivates them to increase their quality. And you might be skeptical of that. It's a little hard to, you know, think about and pin down exactly how much they would change their quality of care. But ultimately, what we really need to believe there is that if we were to raise the Medicaid reimbursement rate, maybe you'd have to do something like raise it, but only if facilities who are taking Medicaid patients improve their quality of care. So there might be some really substantive benefits that way. The last thing I look at is, you know, there are really high quality facilities that don't have enough beds. What if we could pick out some of those facilities that are really high quality and just like add beds to them? Make them larger, assume that they would operate in a very similar way with similar quality. And it turns out that is far and away of the things that I test, the best possible thing we could do is if we could expand the size of these really high quality facilities or, you know, duplicate them next door. You know, I look at the San Diego area and ask, what if I could add 800 beds to high quality facilities? And using cost reports, I estimate that it would cost about, you know, $11,500 per day to add those additional beds to finance it. But it would add benefits that are worth it to residents that are on the order of $27,000, $28,000 per day. And so the cost benefit there really makes a lot of sense if we can find a way to basically expand high quality facilities. So I want to take the last 10 minutes or so of my presentation to actually talk about a different research project, which I've spoken about on a podcast with LTCCC before, which is some of the research I've been doing on nursing home staff turnover, which is really, really alarmingly high because I want to, I think it's informative and helpful to think about this problem as we now realize it's a really severe issue and thinking about what advocates can do potentially going forward to try and help improve the quality of care and staffing that's provided in the industry. So here's a graph from one of my papers in Health Affairs last year, where we did the first large-scale national study on basically all nursing homes in the US and looked at their annual staff turnover rates. And the short story is that turnover rates here are really alarmingly high. We basically find mean turnover rates and are frequently over 100%, and median turnover rates are often almost at 100%. And so turnover of staff members in the industry is dramatic and should really, really, really concern us. Now, you may be asking yourself, turnover greater than 100%, what do you mean, Ashvin? That's Is that even possible? So to clarify, our measure here is basically going to be the fraction of care hours that turn over during a year. So one thing is, when we talk about turnover being 100% or more than 100%, this isn't because we're seeing necessarily part-time staff and we basically treat a part-time staff member who works 20 hours a week as half as important in terms of contributing turnover as a full-time staff member that works 40 hours a week. The reason that we see these 100% turnover rates are higher is not because 100% of everyone left, but actually because the same role frequently turns over multiple times. So most facilities basically have a mix of permanent and short-term staff, and short-term staff turn over a lot. So you might think of a typical facility as, say, having half of their staff who are going to be there the whole year, and then the other half of their staff turns over once every quarter. And so that 50% turns over 4 times in the year. And so you basically end up in that case with what is a 200% turnover rate. And so there's a lot of staff turnover that happens. But it doesn't mean that, I want to be clear, it doesn't mean that everyone is leaving. It means that a large number of roles basically just have constant churn in their staffing, and that facilities have large populations of staff that they're just doing a really poor job of retaining and are just constantly bringing in new people who may not be well-versed or trained with the specifics of that facility, and may not have, and of course then are not going to have long-lasting relationships with the residents, which we may think is important for quality of care. As you would guess, these really high turnover rates are associated with lower quality care, right? If we look at 1-star nursing homes versus 5-star nursing homes with their overall nursing home compare rating, you can see that the turnover rates for these really low quality 1-star facilities are much higher than for the 5-star facilities, though the turnover rates for both are really high and really concerning. And it's not just, you can do it for all sorts of measures. Here we've done it for all of the 5-star ratings, including the health survey ratings, the quality measure ratings, each of the staffing ratings broken out individually, and the overall rating. And you can see that this relationship between higher quality and lower turnover is consistent across the board. And so high turnover here is really a bad sign. It's associated with a lot of indicators for concern. In addition to these low quality measures and 5-star ratings, it's also associated with high Medicaid utilization. So Medicaid eligible residents are frequently at facilities that have really, really high turnover rates. It's associated with being in areas that are really low income and have high poverty rates. It's associated with for-profit facilities. For-profit facilities do a much worse job of retaining their staff and have higher turnover rates. Likewise, chain-owned facilities have higher turnover rates. And there's mounting evidence that it's not just a correlation, that it's actually causing worse outcomes. So recently we had a paper that was published that shows that for the same facility, if you look over a few years, the years where they have turnover that happens right before their health inspections, their facilities are much more likely to be cited for an infection control violation, which makes sense because if you have new staff, they're not necessarily going to be as familiar with the infection control protocol for a specific facility and with the health needs of all their residents that they need to understand as part of their infection control protocol. And there's other research that's sort of on the way that's shaping up that unfortunately is not yet published or public, but the evidence is mounting in that research to come. And I think we're going to learn a lot more about the fact that turnover and poor retention really causes bad outcomes. High turnover, thanks to a lot of great reporting on this work, made headlines in the New York Times and other outlets, and even got cited in congressional hearings. But I want to note that this really shouldn't have been news. The Affordable Care Act basically mandated that CMS cover and publish these turnover and retention measures a decade ago. And they just ignored this requirement for a decade. And basically after a couple of weeks after a lot of the publicity around this, Health and Human Services Office of the Inspector General published a report urging CMS to finally report turnover, just a few weeks after the publicity around the paper. And the good news here is that we were successful. CMS is actually finally publishing turnover rates and weekend staffing measures and other key staffing measures on Nursing Home Compare. So if you have an older family member, you're advocating for someone and you're trying to pick out a facility, I recommend looking at Nursing Home Compare and going into the staff measures and seeing some of these turnover measures when thinking about what facility you're choosing. And basically going forward, starting in the summer, they're actually going to even be including these measures in the 5-star rating system. And so the policy is headed in that direction. So lastly, I'll close by saying, I think that where this turnover research and related work is suggesting is that maybe we want to think about changing the way we measure and reward staffing. As we learn more, it's worth asking, is hours per patient day the right measure? Are staff really widgets where we can just count hours and that's a good indicator of quality? Or can we do more to try and identify what constitutes good staff, right? Does it matter whether staff members have a consistent relationship with their residents? You might imagine that might be particularly important, for example, for residents with Alzheimer's and related dementias to have a consistent care team that knows their needs and also that the resident is more consistent and familiar with. And so as we understand that, then we want to ask, can we actually reward facilities for providing that high quality staffing so that they have an incentive to provide good staffing rather than just many hours? Many hours is important, but we want it to be of caregivers that are really going to drive high quality care. And so CMS including turnover in the star ratings is a good first step. And I think states are now thinking about doing even more. Multiple states have reached out to us after our paper to discuss how they might be able to incorporate that research into the way that they monitor and regulate nursing home care. One state is even considering adjusting their reimbursement rates for care based on staffing tenure and retention. And so as we learn more about what constitutes high quality care, I think it's important that we advocate that we set incentives for facilities that motivate them to provide what is good care. And so I think that's probably, in terms of thinking about what hopefully in the next year or two will be the frontier of making care better, I think that's where I'm most hopeful. So I want to say thank you very much for taking the time to come and listen today. I really look forward to all of your questions in the Q&A. If there's anything that we don't get to or you ever want to chat about challenges and issues in long-term care, please don't hesitate to reach out to me via email or via Twitter. I look forward to taking your questions.
Professor Gandhi, thanks so much. That was really superb and so interesting and informative. If you could stop sharing your screen, I will start sharing mine. Let's look at, there we go. Thank you. And let me go back to my PowerPoint. Oops, sorry about that. So just a few things. Again, thank you, and we'll get to Q&A. Just a few slides from me to wrap us up. One is for materials from today's webinar. Please visit our website, nursingHome411.org/webinar-admissions-discrimination, or if you just go to the website and you look under the Learning Center, you can see the webinars and the links should be there. We also have a new podcast, What 100% Staff Turnover Means for Nursing Home Residents. Actually not new, pardon me. This is, I believe, is the podcast that, that Professor Gandhi and Eric did on the subject. Pardon me. Our next webinar is Tuesday, May 17th, again at 1 p.m. Eastern, and it's going to focus on staffing. We're calling it Starts with Staffing Requirements and Recommendations for Providing Safe and Quality Nursing Home Care. Again, if you go to our website and look under the Learning Center and webinars, you can sign up for it there or register here. You can see a bit.ly, bit.ly/staffing-recs for requirements. And what we're going to do in this program, I mean, obviously we talk about staffing a lot. Professor Gandhi just talked about staffing. It's the number one issue as far as I'm concerned in terms of nursing home quality, for a variety of reasons. As Professor Gandhi was saying, both the quality of the staff and the quantity of the staff are really important. So what we're going to do in this coming webinar on May 17th is we're going to talk about some of the existing requirements for both safe, sufficient, and sufficiently equipped and trained staff, because those are important. The reform law, the Nursing Reform Act, as Professor Gandhi was talking about it, from 1987, requires that nursing homes have sufficient staff to meet the needs of their residents, and those staff have to have the appropriate competencies and training. And those requirements, even though there so many nursing homes are significantly understaffed and other staffing issues, including the staff turnover, as Professor Gandhi was saying, are significant issues. The requirements are there, and the requirements, I think, are actually quite good throughout the both the regulations that are implementing the Reform Act or the Reform Law and the guidance for understanding that. Unfortunately, they're not very well enforced, as our November 2021 study from 5 months ago now found, is that staffing is rarely cited by state surveyors, even though the majority of nursing homes don't have sufficient staff. So what we're going to do is I always want to talk about, that the standards are there and everyone has the right to good staff and appropriate staffing with the appropriate competencies. But this is something that's been part of the new White House proposal to reform nursing homes. So I think that's really important. The president has said that he's going to commission a study that's supposed to take place within this year on what sufficient staffing means, and then to implement regulations to require that of nursing homes. We think this is extremely important. In addition, the National Academies of Sciences, Engineering, and Medicine, NASEM, they just came out with a report about a week or two ago, I think now, that looked at nursing homes and what is needed to improve nursing home care. And they call for 24-hour RN staffing, as we have for many years, and other important improvements to staffing. That report is important because it was a previous report from that same body, then called the Institute of Medicine, in the mid-'80s, that actually led to the federal nursing home reform law from 1987. So this study is also going to be important. And then what I really wanted us to focus on next month is talking about how advocates and family members and organizations that work on behalf of residents can effectively respond to the president's call for input on what these staffing rules should look like. The nursing home industry and their many lobby associations will be putting in input from individual facilities and from the lobby associations, et cetera, saying that any rules requiring minimum staffing are unfair. And they're already doing that with the press, and they're doing that on the Hill, et cetera. So I think it's really important for people on the consumer end who want to see good protections and good quality of care be able to speak about this and be able to weigh in with the proposed rules as well and as strongly as possible. So that's going to be a significant focus of our next program, and I hope you'll join us for that. With that, I'm going to we'll go to Q&A before I end my slides. For updates and invites to future programs, please go to nursinghomes411.org/join. We don't sell all this, we don't share all this, so you can be sure that your name and contact information are safe. And then for long-term care ombudsman, we have changed our SurveyMonkey for this. So for the survey, it's a very quick survey now. It could be for if you're in New York or any state, if you go to surveymonkey.com/r/LitCop1, and you attest to having attended this program and put in your name and an email address, we will send confirmation that you attended this program to that email. But I think what we're going to do, just so you know, going along, is that I actually found out today that we send a confirmation to people afterwards who have attended the program. So I think that that should suffice to share with your ombudsman supervisor that you've attended the program. And I hope that you do find it useful as ombudsman. I am really happy to see that we have a lot of ombudsmen here today and have in the past. So with that, I'm going to provide some questions for Professor Gandhi. One, Robert Roseth, I hope I'm pronouncing your name correctly, asked, is there comparable research at other kinds of elder care facilities, such as assisted living? Is there reason to believe that the situation is similar, i.e. various forms of financial discrimination?
Yes, so the short answer is no, there's very little research in general on assisted living or other forms of elder care facilities, unfortunately, including home health, because sadly, the data is really lacking. There's almost no federally collected data on assisted living facilities. You can't go to CMS and even get a list of them. And so the research, assisted living and other elder care facilities are just as important as nursing homes, but the vast majority of the research is always going to end up being on nursing homes, because that's where we can do things like look at every single resident at every single nursing home in a given state over multiple years and really show really convincing statistical evidence. If you ask me, I would guess that almost certainly these are happening at other forms of facilities, given that there are similar financial incentives and even less oversight and regulation. And of course, the nursing home industry, I think we all know, often, even where there is regulation, the oversight or the punishments for failing to meet those regulations are often lacking. I also want to quickly answer, I accidentally clicked answer to Sandra's question. So I want to answer that before we go on as well.
Sure. So that was Sandra McDonald asked, I wonder if there was another industry that has this type of staff turnover.
Yeah, so the answer there is yes. There are a few industries that economists know have really, really high turnover rates. It's hard to say whether any have the same level of turnover, quite at this like greater than 100% being very common as nursing homes, because actually this is basically the only instance I know of where we have access to daily data at an industry level to really very, very specifically tell you about turnover that happens multiple times within the same years. But if you go back to economic studies of which industries have really high turnover, there's something that's fairly consistent about them, which is, they involve industries like retail and food service and trucking, industries where the work is very difficult and is often very poorly reimbursed. Where basically the staff or the workers are not paid very well. And so that's the fairly consistent predictor of where you see really high turnover, is where job is hard, people aren't paid well. And unfortunately, I wish I could say this was just nursing homes where we see this problem, but unfortunately, I think this is true for a lot of industries. Here, there's this really, I think the really, really unfortunate additional consequence in the healthcare industry is that there's the impact also really hurts, really in a very dramatic way, hurts residents. Whereas I don't think there's quite that same dramatic health impact or adverse consequence in, say, retail for the consumer.
It's a great point. Thank you. Can you address how a Medicaid-approved facility can turn people away because they only have 4 Medicaid beds?
Yeah, so there, as far as I know, there is no legal grounding for saying that your bed is a Medicaid bed if it's been certified, because almost every facility has every bed certified for Medicare and Medicaid. And so when facilities say, oh, we only have this many Medicaid beds, the fact that it's a Medicaid bed is just a completely made up fictional thing for, they don't want to take more than a certain number of Medicaid patients because it cuts into their profits too much. That's what they're basically telling you. Anytime a facility tells you, oh, we only have X beds, where X is less than the total number of beds they have, 99% of the time, that's just discrimination. Now, whether that's illegal discrimination or not, I think ends up coming back to this legal question of, is turning patients away on Medicaid illegal, or is it only illegal if you say, we'll admit you if you end up not being on Medicaid? And so it's a really, really weird loophole. And I hope, knowing that we have so many great advocates in the audience, that that some of you are able to, or have connections, are able to better advocate or push on this, because I spent many, many days trying to find case law and talking to a number of different lawyers, and it isn't there. And I think that ambiguity leads to this type of misbehavior where there isn't a clear way to say, no, that's wrong. That's clearly discrimination.
That was such a fascinating part of for me, a fascinating part of your presentation was talking about that. I'm going to quickly answer Barry Bertel's question. What does CMS mean? It's the Centers for Medicare and Medicaid Services, and that's the federal agency that oversees nursing home care and other hospital care, hospice care, et cetera. And then we'll do one more question from Sarah Traylor. Is there a large plan to end agency usage or make it less appealing for nurses staff to want to be on an agency staff versus being staff of the facility?
Yeah, so as far as I know, there is not any plan to end agency staff or to penalize facility for using agency staff. So for those who don't know, agency staff here meaning contract staff, those who are not employees of the facility. And something that's starting to fall out of some of the research we're doing right now is it looks like agency staff or contract staff don't have additional hours of those staff, don't have the same positive benefit for resident health as additional staff hours for more consistent actual employees who have been at the facility for a while. And so I think this is exactly the type of question that we want to be asking going forward, both as researchers, but also advocates, in terms of, can we do a better job of figuring out what exactly is going to drive high quality care? And I think that, again, not published yet, but if you ask me to take a bet, I would say that the preliminary findings we have are going to hold up, and agency staff are really much less good for health outcomes than more long-term staff.
That makes sense, because there's been studies on consistent assignment showing the benefits of consistent assignment. So that, having agency staff has to undermine the consistent assignment of, from a staff member to a resident. Well, again, thank you for a superb presentation, Professor Gandhi. Thanks everyone for joining us, and we look forward to seeing you next month. Bye-bye now.
Thank you very much. Take care, everyone.